All right, well, welcome everyone. Good afternoon, good evening. I think we'll get started here. I'm Zishan Sardar, one of the hosts for today. Um, we'd like to thank everyone for joining us for this webinar hosted by the Cervical Spine Research Society. Can we go on to the next slide, please? Yeah, today we have an exciting agenda today where we're going to focus essentially on cervical spine deformities. I'll give a small introduction to cervical sagittal alignment, followed by really discussions on techniques for deformity correction, including anterior cervical osteotomies as well as posterior three-column osteotomies, and then we'll have a presentation and discussion at the end. I'm hoping we'll learn a lot from this session today, and with that, I'll let Dr. Byron give a few announcements.
Yeah, thanks, Zishan. So just a couple of reminders for everybody. The CSRS annual meeting is December 3rd through 6th, and registration is open now. Early registration ends soon, so go ahead and get registered for the course. Another reminder about our Emerging Leaders course. This has been I would say, wildly successful endeavor that several of my residents and fellows have raved about, and early practice surgeons. It's for orthopedic and neurosurgeons in their first 5 years of practice and neurosurgeons in the last year of residency. Applications can be accessed through this QR code, and they do close soon on October 15th. So put your application in. And then finally, a reminder to connect with CSRS on your social media platforms at the handles that you see listed here. And subscribe to our YouTube channel where this video will be posted at a later date. So first up, we're blessed to have some real leaders in the field of cervical spine surgery, and particularly cervical deformity surgery tonight. And our first speaker is my co-host, Dr. Zishan Sardar. Zishan is an associate professor of orthopedic surgery and neurosurgery at Columbia University, and is going to give us an overview of sagittal alignment and cervical spine deformity. Zishan?
All right, thank you very much, Byron. Do you mind stop? We have to stop sharing this, and I'll start my talk here. All right, perfect. We'll get started here. So I'm just going to give a very short 5 minutes or so introduction on just some key concepts in cervical spine sagittal alignment. Nothing too fancy, but the goal of this was to have a bit of a baseline set for everyone on this webinar so that we can then understand the following talks a bit more in terms of the goals that we're trying to achieve. Here are my disclosures, nothing relevant to this talk. And so I just wanted to quickly introduce some of the key parameters that we look at in the cervical spine. One of the most common ones is obviously the C2 to C7 cervical lordosis. There are many different ways to measure this depending on which research papers we read in the past. But a common way is to measure it from measure the Cobb angle from the inferior end plate of C2 to the inferior end plate of C7. And so this is our main C2 to C7 lordosis. The reason I have it crossed out here at the top and instead I'm calling it cervical sagittal angle is because, as we know now, not all patients have a lordotic cervical spine. A lot of patients may have a bit of kyphosis, which is normal. The next important parameter is the C2 to C7 SVA, sagittal vertical axis, which is essentially a vertical line drawn from the C2 centroid. And then we measure the distance from that line to the posterior superior corner of C7. And a distance of more than 4 centimeters has been correlated with significant disability as well as worsening neck disability index. Next, we have T1 slope, which essentially is the equivalent of the sacral slope, but for the cervical spine. And the T1 slope is important because a large T1 slope means that the person requires more cervical lordosis to be able to keep a horizontal gaze. And if you have less T1 slope, you then require less cervical lordosis. Also, there have been studies that show a high risk of post-laminectomy kyphosis as well as distal junctional kyphosis in patients who have a high T1 slope. So this is an important parameter to look at and to address. And the last one in terms of parameters that I want to just touch on briefly is the chin brow vertical angle, which essentially measures a person's ability to be able to look straight ahead. And again, different numbers have been published on this parameter, but anywhere from -10 even up to +20 is considered to be under within the normal range. Quickly talking about some of the asymptomatic volunteer studies that we have been doing through the MEAN study group. And essentially what we have found is that the cervical sagittal angle or lordosis, in fact, in the younger age group, patients have a slight bit of kyphosis that eventually transforms into lordosis in the mid 50s to older age groups. And so that's why we wanted to really specify that it's not always cervical lordosis. The T1 slope in this asymptomatic volunteer population also increased in the older age group, mainly with an increase in thoracic kyphosis. And so the T1 slope increases, the cervical sagittal alignment or angle lordosis increases, but these SVA, the cervical SVA remains relatively stable, which means that the cervical spine is still across ages trying to keep the same CSVA regardless of age. And so does the T1 slope and CSA difference remains relatively stable as well. And here's a representative picture that shows with different age groups from our volunteer population, patients increasing in kyphosis of the thoracic spine, increasing T1 slope, and also increasing, then going from cervical kyphosis to cervical lordosis, but maintaining the cervical SVA. And so based on essentially what we then did was we came up with thresholds based on two standard deviations. And interestingly, that it was very close to what's been published for symptomatic individuals in terms of the thresholds where the disability increases. So the T1 slope threshold was about 40 degrees, cervical SVA 40 millimeters. And then the CSA T1 slope mismatch was about 25. And based on that, we try to classify the type of deformity into a few different groups. And obviously there are other classifications, one by Dr. Ames, one by Hanjo, and a few others as well. But just to quickly show those four different types, type 1 is essentially normal cervical alignment where the person has a normal cervical SVA. So this is more stuff your 1-2 level degenerative conditions or just asymptomatic individuals. A type 2 is a primary cervical deformity, which what that means is that patient will have a lower T1 slope, but a high cervical SVA, which means that the high cervical SVA is essentially being driven by the cervical spine itself and not by anything else. And then we can have a primary thoracolumbar deformity where the T1 slope is high, but the cervical SVA is still maintained by the increase in cervical lordosis. And here the problem really is the thoracolumbar spine. And lastly, you can have a combined deformity in a patient like this, where we do have extremely high thoracic kyphosis, we have a high T1 slope, but also the CSVA as well as the T1 slope and cervical lordosis mismatch is high. And so this person is someone who has a combined deformity and eventually requires a C2 to pelvis type of reconstruction. And here is a summary figure showing the different morphologies of alignment when it comes to cervical spine. And the goal of this is really to be able to understand where the deformity is coming from so we address the appropriate region. Here's, based on previously published literature, some of the summary key alignments are as follows. The CSVA is somewhere between, it has to be less than 35 to 40, T1 slope less than 35 to 40, T1 slope and cervical lordosis mismatch somewhere around 18 to 25, and the chin brow angle between -4 to 10. I think I'll stop as far as the parameters are concerned here. I do want to show that not all cervical spine deformity needs surgery. This is a patient that I have followed for a couple of years. She sits holding her chin in her fist like this and says she has no problem. She does not have myelopathy, and she's been going along like this. So obviously, parameters are parameters, and we do have to take the clinical picture into account as well. And we recently published a paper for those who are interested in just reviewing sagittal cervical alignment and for deformity. And with that, I'll stop. Thank you very much, everyone, for listening.
It's a great overview, Zishan. Thank you for that. I think it's a really important reminder, especially for the residents and fellows and young surgeons. We treat patients, not X-rays. With that in mind, it's my honor to introduce our next speaker, Dr. Dan Rue, a man who needs no introduction, former CSRS president, professor of orthopedic surgery and neurosurgery at Cornell and Columbia. Dr. Rue, thank you for donating your time tonight, and we look forward to your talk.
Hey, thanks so much. And it's great to see so many former fellows and visiting surgeons and friends from all over the world on this webinar. And thanks for giving me the opportunity to give this talk. So these are my disclosures, and I'm going to talk about I was asked to talk about anterior osteotomies. And I always tell fellows what's the three most important things for cervical deformity correction when you're doing an anterior osteotomy. And as you can see here, 1, 2, and 3 are really positioning, positioning. If you don't position this patient adequately, you will never be able to correct that deformity. So what you have to do is you want to keep the head as far off the bed as you want to correct. So when you start out like this, and then you do the anterior osteotomy. When you are done, the head hits the bed, and that's as much as you can correct. Because if you start in this position, unless you get a skull fracture or you can drive the head through a steel table, you are not ever going to be able to push this head back. So if they have an abnormal C2 to C7 sagittal vertical axis or a cervical kyphosis, they start out like this. They have a very stiff deformity, so the head is standing up in the air. You start out with a bunch of sheets under the bed, and then you end up pulling those out, and I'll show you how to do that step by step. So preoperatively, I assess patients and see how flexible their thoracic deformity is, and I say, this is how much we want to correct their cervical alignment by. But he's actually hyperlordosing his lumbar spine, and when he lies down, the thoracic spine becomes flexible, it flattens out, and so that distance is much less than the distance that you actually want to correct his alignment by. So what we do is we tell the patients that we want to get an EOS image. This patient came to me after having had a bunch of operations, and we look at this and we say, okay, I just need to correct about that much. So that's the distance that I need to correct, and that's the distance the head needs to be off the bed, correct? Well, you think that's correct, except for the fact that when you send this patient for an EOS, what they all do, including this patient, is they hyperlordose their lumbar spine so that they can maintain forward gaze. And in addition, the EOS text says, now stand up straight. We want to get a good picture. So they do their valiant best to stand up straight. They hyperlordose their lumbar spine. They hyperlordose their thoracic kyphosis, and they're all leaning back so that they can stand up straight. So that when you go to measure them, you say, well, this person doesn't need any correction. The neck looks pretty good other than, some curvature. This person only needs a correction like this. This person needs a correction like this. And so I didn't understand that when I was first doing this, and I would undercorrect everybody and wonder, why am I undercorrecting people? It's because you need to start with the head in a supported position, but the most important thing is you need to tell the person to be in a relaxed posture when they go for those x-rays, so you have a good idea of how much the head needs to come back. Once you've done that, you start them with these sheets, and I ask anesthesia to pull these sheets out as we're doing the surgery. So the next question people ask is, okay, they have a kyphoscoliotic deformity. How do you get into the anterior cervical spine to do the surgery? So this patient, head, chest, left, right. So usually they are tilting their head to one side, or there's a little window of opportunity to get in. This is after I dissect. This is the spine. It looks like spinal cord, but it isn't. It's actually the right on the spine, and this would be about where the autofusion has taken place. So once you've done that, how do you locate this fused disc space? Because when you go in there, everything looks like one massive sheet of bone. So what you have to do is find the uncinets. Once you find the uncovertebral joints, and even in a solidly fused spine, you can find those uncinets. I use a Penfield 2 or Penfield 4 to get lateral and find where there is. Sometimes there's a bump there where the old disc used to be. Sometimes the patient has had an iatrogenic deformity and they've had a discectomy infusion, so you can find that easily. But if you can't use any other technique, just find it with a Penfield 4. Once you've done that, all you have to do is put a Penfield 4 on one side, a Penfield 4 on the other side, and then you just burr right across until you get to the PLL. If you can do an ACDF, you can do this procedure, and it's not that difficult to do. This is a pretty simple maneuver. And most people who have done it the first time say, wow, this is easy. This is much easier to doing a pedicle subtraction osteotomy, because all you have to do is just do basically an ACDF with a burr. So once you've done that, you go through the lateral uncinets, you crack through all of that material. Now you have removed all of the anterior barriers to extending this area and causing a fracture, control fracture through the facet joint in the back. So we've done this. Now we ask anesthesia to take out some of the sheets in the back, and then through the sterile drapes, we push down on the forehead, and then it cracks right where, and it's an opening crack. So the foramen opens up, and you get a very gentle, and you take out one sheet at a time, it gradually opens up. You can even use two Caspar distractors to do that, to hold it in place. So this is me operating. So when I was at Columbia, I take some sizers, like a 10 millimeter. I start out with like a 5 millimeter sizer, put it in, I mallet it in, and then I push down on the head as I'm rocking this back and forth and gradually opening it up. And that opens it up. Anesthesia is taking out one sheet. And this is what it looks like in after we've removed all the bone and all the disc or whatever material that you've got left. This is through the microscope, and this is outside. Now I'm pushing down on the head as I crank on the distractor and put in ever larger sizers to get in there and expand it out, mallet it in, push it down, and then it's basically after a little while, it's going to start staying there because I'm putting in bigger and bigger sizers and getting more and more of a distraction. And then eventually I put in a graft and we're done with that osteotomy. And that's as simple as what it is. Once I've done that, I now use standalone cages and just put one screw into it so I can get further correction in the back. This was a case a long time ago when they still had these screw-in cages. So I was using those screw-in cages, which also works very nicely, but they stopped making those. And now I have to use these standalone cages, which work very well. So you get sequential. Oh, one thing I forgot to say, this is after the anterior. This is after we position the patient, we get intraoperative X-ray. I put in a distractor pin, and after the distractor pin goes in, I do the anterior osteotomy. You can see how much correction you can get with just the anterior. The posterior has not broken yet. So then we go in posteriorly, and then we just do a Smith-Peterson osteotomy through the facet joints, and then it corrects. You can go from this to this, starting with this, with it ankylosed both front and back. So it's a two-stage. You do the anterior, you get most of the correction, and then you finish it off with the posterior. And this is a case where the patient has a kyphoscoliotic solid fusion. We do one level at a time, and we can get them corrected nicely, both in the coronal and sagittal plane. This is a patient with hemivertebra that we did. Now, in this patient, I told them, when I correct your coronal deformity, you're going to get a C5 palsy on this side, because I've had that happen enough times with the coronal plane deformities that I now know to expect it. Unfortunately, the patient did fine on this side, but developed it on this side. And it was probably because I didn't do enough of a foraminal decompression. And I had no idea which level was causing that. It looks like an erector set here, but at least his spine is straight. He's very happy with the results. Couldn't tell which one of these levels was causing that. Couldn't really see anything, but ultimately at 6 months, he was still having a C5 palsy that had gotten much better, but not complete. He was solidly fused at that point. So I took him back, took out some screws, did more foraminotomies, and he improved immediately upon waking up from anesthesia. So it is possible in a coronal deformity to squeeze down a nerve root or to stretch it on the concave side. So you can see I took out a bunch of screws here, and patient wakes up with a normal neurology correction from here to here. You can see it better without all the erector set in there. Another patient with a kyphoscoliotic deformity, ankylosis, and she's corrected. You can see preoperatively she's leaning back here a little bit, and she corrects that a little bit. So you really have to tell them just stand in a position of comfort, even if it's really not something that you would normally try to do, because that way I won't undercorrect you, because undercorrection is a significant problem. The nice thing about an anterior posterior osteotomy or an anterior osteotomy followed by posterior stabilization, you can do it way up high. If you're doing a PSO, you're generally doing that at C7, T1, T2. If you're doing this and you got an ankylosed spine up here, you have a choice of leaving this kyphotic and doing something back here and removing all the stuff that they did. Or anteriorly, you just go in. She's got a head off the table, as you can see in the examining room preoperatively. Going in anteriorly, I find where I'm going to do this, put in Caspar distractor pins, go in, crack it open. This is the intraoperative AP. This is the intraoperative anterior, and then I go in posterior and fix it. And pre-op, post-op, sagittal and coronal correction. You can see pre-op X-ray, post-op X-rays, EOS post-operatively, and you can get this kind of a correction without having to do a pedicle subtraction osteotomy, which would be difficult to do at C3-4 and C4-5. You got the vertebral arteries in the way. It's going to be bloody. You're doing half of it blind. Now, the one time that you actually will not have trouble overcorrecting is when you take somebody who's got ankylosing spondylitis who's fused to the skull, because it is easy to overcorrect this kind of a patient. And I used to do these as PSO also, but now I've started doing these anteriorly. It's again pretty easy, but the problem is if you overcorrect, they can't see the feet. I go in anteriorly, again, do this. It cracks by itself in the back. I just go in and stabilize, and they're fine. So I corrected him like this. He said, I can't see the feet. He was ecstatic for a while, goes home, says, I can't see my feet, comes back. I had to take some of the correction out. So it's halfway between this and this is what he ended up with. And then he was happy because he could see straight, but he could actually see his feet when he was going down the stairs. So how do you prevent that overcorrection? Once again, you either take a look at a picture or send him for an EOS where he's kind of leaning back. And I say, I don't want him back all the way here. I want him so he can look straight ahead. So I measure what that distance is going to be. And that distance is equal to the distance that his head is there. And I put a sandbag here so that when his head touches the sandbag, we've got the perfect correction, exactly the amount he wants. And then I start out with a bunch of sheets. We pull them out one at a time. When we're done with the anterior, his head is touching. I got exactly the correction that he wants and that I wanted, a little bit from here to here, not so much that he can't see his feet, but much better than this so that he can look straight ahead. And that way you can avoid the overcorrection that you can get when you do patients with ankylosing spondylitis. So in conclusion, remember that the most important thing when you're doing this is proper positioning. But before you do that, you got to get an EOS, and you got to tell the patient and the tech, you have to have the patient in a relaxed stance, because otherwise they're going to try to overcorrect and then you'll end up undercorrecting. It is much easier to undercorrect than overcorrect a deformity, except when you're dealing with ankylosing spondylitis, when if you are dumb like me, you can overcorrect and end up having to take the patient back for a re-correction and making them more kyphotic. So thank you so much. And that'll be the end of my talk.
Thank you very much, Dan. Maybe we'll do a couple of questions before we move forward, if that's okay. I think there's a question in the chat about tips and tricks for removing the uncomfortable joint safely and easily. I think you did show a picture. You mentioned it, but maybe if you want to just briefly say it again.
Sure. So what I'll do is I'll share this part of the slide so you can see. The key is to put a Penfield 4 lateral to the uncinate to protect. So I put a Penfield 4 or Penfield 2 on the other side. And then with that in place, well, what you want to do is you want to make sure that with that in place that you go from side to side. This Penfield protects you from hitting the artery here. This Penfield protects you from hitting the artery there. And this is what it looks like intraoperatively. Whoops. this is what it looks like with the Penfield 2, Penfield 4 on the other side. And then this is what it looks like. I'm burring here. I got a Penfield over here. And once it gets very thin, then you can just end up taking a curette and going from outside in, or just take that Penfield 4 and just pull it in, and it will go ahead and break through the remaining uncinate. And that's the easiest way to do it. And once you got that Penfield 4 in, it's pretty simple. I mean, I've had guys who have finished their fellowship and have gone out to do this in their first or second year after fellowship. And they say, this is much easier than doing, I've seen PSO and things like that, and it's much easier to do that. And I see Andre. Hi, Andre. Joachim and Andre is asking, how do you choose which level? I just take the easiest level to open it up. Usually for ankylosing spondylitis, the lower you go, the better it is. So I would recommend like C6-7 if you can reach a C7T1. But sometimes, they have multiple levels. They're kyphotic, and you can do multiple levels. It's like doing a 2 or 3 level ACDF.
I think in the interest of time, we'll move on to our next speaker. That was a great talk. Thank you, Dr. Rue. Our next speaker is Dr. Chris Ames, professor and director of spinal deformity surgery at the University of California, San Francisco. Thank you, Dr. Ames, for volunteering your time for tonight. Thank you.
Well, thanks, guys. Thanks, Byron and CSRS for letting me show some of our work. I really took a step-by-step approach to this, which I think is important as you learn the procedure and kind of optimize technique. My disclosures are listed here. So step one has been discussed a little bit by the other speakers, but it's important to identify the patients that are most appropriate for 3-column osteotomy. These are typically the patients that have a T1 minus CL type deformity, where their head is significantly translated due to a high upper thoracic slope or high T1 slope parameter. It's not for the patients that have a low T1 slope and have a pure cervical deformity typically, although occasionally we will do these in the cervical spine, as Dan mentioned. Typically, these are done in the C7 T1 to T4 region. These are the group 3 deformities using the Hanjo-Kim classification. And also, these are the rigid type 3 deformities using the European CSRS classification as well. This is a typical example of this type of patient with a translated head. We use the external auditory canal as the center of gravity of the head, and I look for the external auditory canal lying in front of the neck skin crease. On exam, this is a pretty good indication. The other thing we look at is extension reserve. I didn't put a slide in here, but we ask the patients to look up. Typically, these patients are at maximum extension just to barely be able to obtain, if possible, horizontal gaze. So this is the archetypical patient where they're going to need a correction of the T1 slope, usually through an upper thoracic 3-column osteotomy. Yeah. One of the important things is to eliminate the patients that don't need a 3-column osteotomy, because these do have high complication rates, as I showed toward the end of the talk. So we examine the patients in the standing position as well as in the supine position to look at flexibility. And although it kind of tortures the patient a little bit, you can see this patient is semi-flexible and probably can get by with either an anterior-posterior technique or an all-posterior type 2 technique. We published the cervical release and osteotomy classification a few years ago just to try to give cervical deformity surgeons a common language. It wasn't really to tell them what to do, but so when we spoke about these types of procedures, we could speak a common language and look at complications. I'm going to touch on very briefly the lower grade posterior column osteotomies and show you a couple case examples. This is a typical case that has a significant disc collapse and cervical kyphosis. For this type of patient, we favor an anterior-posterior technique, a little bit like what Dan mentioned, but we don't have to go out as far laterally because this patient is not fused. We use anterior cages to increase the interpedicular height, and then a posterior type 2 osteotomy to close it down in the back. So a typical case example of this, we use a single screw per level. And the really important part is when the discs are collapsed, when you're going to perform a posterior closure using just a standard PCO technique, you really have to build up that interpedicular distance a bit, or you can get iatrogenic foraminal compression. That's a very important distinction that's really improved our complication rates over the years. If you're going to use an all posterior technique like we did in this case that has some disc collapse, a really important pearl is to remove the superior articular process. Typically, surgeons early in their careers, as they're doing these, will just kind of drill it out. And you really have to go underneath the lateral mass above and remove that superior articular facet fragment. Because when you close that down, that fragment that's now free after the complete facetectomy is going to compress down on the nerve. Sometimes you even have to remove a little bit of the pedicle if you're going to try to do this from an all posterior technique. And I'll talk a little bit about the pedicle screws in a moment. And then for these PCOs, we essentially perform a combined technique where we elevate the head and we slowly march down after locking the instrumentation proximally. We perform a standard cantilever reduction, elevation of the head, cantilever on the rod, and we march our way down using standard reducers that are common in deformity surgeries. These are common for deformity surgeons, but a lot of times the degenerative surgeons are not that familiar with those. So these are the standard reducers we use to perform cantilever technique, and we typically will go below the thoracic apex in these patients as well. The next important step is optimization. The cervical deformity patient represents a very unique patient compared to thoracolumbar deformity. They have a much higher incidence of sarcopenia, frailty, medical comorbidity, neuromuscular disease. Many of them are very deconditioned, they're malnourished, and many of them have poor bone mineral density. So it's very important to work them up and optimize them prior to surgery to optimize their outcomes. On average, our patients are losing about 10 to 15 pounds after these procedures in the perioperative period. So if they come in nutritionally depleted, they're going to really be cachectic and have poor healing post-op. So very important to optimize them, check their swallowing function. Sometimes they may even need a peg tube pre-op to optimize their outcome. This is a typical patient that would come in with a PJK and very severe, kind of disproportionate cervical deformity to the PJK due to muscular wasting. You can see she's frail, sarcopenic. This is a typical patient that would need a lot of optimization prior to surgery. Okay, step 4, the planning. We look at the apex and the T1 slope to identify the appropriate 3-column patient, as I mentioned before. We look for the driver. Is it upper thoracic kyphosis? Is there a high deformity angular ratio right at the cervical thoracic junction, for example? Is it a sloping kyphosis in the mid to upper thoracic spine, or is it purely severe thoracic kyphosis? We ask them to perform a position of comfort X-ray. This X-ray, as Dan mentioned, where he says it's a relaxed X-ray, we call it position of comfort. It doesn't matter. But essentially what they're doing is relaxing their compensation. When their compensation is relaxed, then you can measure the appropriate osteotomy angle. If you measure them out and plan them when they're compensated, then your correction will be, you'll have undercorrection, or you'll have persistent compensation after your correction, and persistent, typically suboccipital neck pain. In the high PI patients, we typically will go lower in these patients, so lower LIV due to the different inflection points. And then all of these patients, as I mentioned, undergo bone mineral density optimization. Not so much for the cervical spine, where it's not as much of an issue, but for their LIV, it's a huge issue, and DJK is the bane of our existence in cervical deformity surgery. I just mentioned this in passing, but we have now used all custom implants, custom rods for these. There is no predictive model to look at distal equilibration like there is with custom rods and TL deformity. So this is really done with heuristics and estimation at this point, but it does help to translate the preoperative plan to the postoperative result, and the back of the occiput to the back of the thoracic apex as well. So right now it's just heuristics. There is no AI involved in this custom rod process, but we've switched over to it for the last several years. Another aspect to this, which can be challenging, is access planning from the back. Dan mentioned some of the access challenges from the front. We have occasionally access challenges in the back where these patients can be extremely rigid, and you can't even unwind them enough to place their cervical instrumentation until you perform an osteotomy to correct some of the thoracic kyphosis so you can unwind to some extent their cervical hyperlordosis. So be wary of that. Sometimes it's good to have a partner there if you're going to plan to do multiple osteotomies at the same time. Okay, step 6. This is critical. Tony McCullough is in the audience. He's one of my fellows, and this is really his work on Hounsfield units, which has been transformational for us. We look now very carefully at the LIV for the Hounsfield units. If the Hounsfield units are under 130, we really try not to stop short in those patients and try to find a better level that has higher bone mineral density to stop. If it's about 170 or above, usually you're good and you're not going to get a significant distal junctional failure. Even better than finding a high Hounsfield unit level is to find a level that's autofused. Many times these patients have severe degenerative disease, they have spontaneous fusion. If you can identify a level that's autofused, it really has extremely low DJF rates. We've tried everything over the years. I've made all the mistakes, so you don't have to. The Schurman's rules, like the first lordotic level, the sagittal stable vertebra for your LIV, they do not work in the cervical spine. What do we do if we can't find a Hounsfield unit level or a patient has concomitant lumbar deformity or other risk factors like sarcopenia, multiple compression fractures? We go to the pelvis now on some of these patients, either in a stage fashion or primary. They have basically almost no failure. And you can see they're not as limited as you think in terms of their mobility. Many of them can bend over, touch their toes, and walk fairly normally. And this is something that we have switched over to in patients that just have risk factors that cannot be mitigated prior to surgery, where we can't find a level with adequate Hounsfield units. Okay, now selection of the level for the three-column osteotomy. We now avoid C7 and T1 if at all possible because the neurological deficit rate at these levels is quite high. I'll show you Tony's paper from JNS in a moment. We've essentially abandoned them unless the deformity angular ratio, the apex, is really just focal at C7T1. Then we'll take it on, but we very carefully counsel the patients that the C8 palsy rate at these levels is quite high. This is from Tony's work where he looked at our series of three-column osteotomies at neurological deficit rate by level. You can see T1 was just the absolute worst in our series in terms of having any sort of hand weakness after surgery. If you have a patient and you do a lumbar PSO and they have 3 or 4 out of 5 strength in their quadricep, it's not a huge problem. They typically ambulate and get better. If you have a patient that has a dominant hand weakness, even 3 out of 5 or something like that, those are miserable patients. And we have not found a way. We've done everything over the years, taken the rib, not taken the rib, closed slowly, closed more quickly, dissected the nerve out, not dissected it as much. We haven't found a way to avoid C8 palsy. For three-column osteotomies, we prefer, in my practice, to have the head well fixated. I know Dan prefers bivector traction. We use this OSI attachment for the Jackson table, and it allows us to lift up, correct coronal deformity, correct rotational deformity, all at the same time in a very controlled way for our closures, and I'll show you the technique for that. For positioning, many of these patients might have very severe deformity, like in the AS patient population. We build these, I don't like the sitting position, so I build the patient up as much as I need to using towels or blankets on the chest. I have not found a patient yet that we could not do in the prone position if we built them up enough. Sometimes we're standing on 3 or 4 levels of steps to do the surgery, but we've not had to resort to the sitting position just yet. Very critically important and something that has transformed our practice over the years. We use all pedicle screw constructs now in these patients when at all possible, which is almost more than, certainly more than 95% of the cases. We use navigation for it. And something that's been a bit transformational for us is we now use craniomaxillofacial plating to eliminate motion in the cervical spine for the registration. And furthermore, it allows us to go in with the navigation probe prior to placement of screws and double check our navigation accuracy by checking it on the screw placement within the plate. It takes literally 2 to 3 minutes to put this plate on. It eliminates motion and it improves accuracy significantly. And when you can place pedicle screws, you can really pull on the cervical spine. You don't get the failure that we saw with lateral mass. Okay, now to go over the procedure in detail, we use racks to stabilize the spine during the osteotomies. We use sometimes the regular PSO box chisels, sometimes the miniature chisels from the cervical deformity set. And essentially, it's very similar to the PSOs that you might do lower down. If there's a lot of ventral compression, then we'll use a drill to try to avoid kinetic energy transfer to the cord. Usually there's not. Usually it's purely deformity, and we can use chisels to perform the osteotomy like this, and it's quite quick. If the bone is a bit harder and it's not taking the chisel well, we use a conical tap. These taps decancellate the vertebral body very quickly. You can see there it's being used on the right side of the screen. And once you use that conical tap, really it's a few blows with the box chisel and you're nearly done. These are very quick procedures typically. The racks, basically every company now makes these racks for stabilization for osteotomy. They come with 3/5 or 5/5 6/0 rod attachments, and so they're easy to use. This is a typical PJF case where we're using a W connector for the attachment. And you can see the central impaction by the spinal cord there. And now the closure. So this is a key part. We've changed our techniques over the years. For the closure now, we lock the rod proximally. We then take the racks off and we place the reducers distally. The patient is supported in the halo ring and they're supported on the Jackson table. We have not seen translation in these patients. We don't take all of the anterior cortex of the bone though, so that's very important as well to prevent translation. But in one of the key aspects to the closure is it's not purely a posterior translation. It's also a posterior rotation. So by completely disconnecting and grabbing the head, we're able to rotate as well as translate, and it's very controlled as it's going into the reducer. So here's an actual case. Again, the screws are locked proximally. I'm lifting up on the head. The osteotomy is closed down, and my partner's controlling the rod with the reducers in place, and then we'll use the towers to reduce that distal rod down, obviously checking the motors. On the table, we reconcile with the back of the head level to the thoracic apex. That's the best way I've found to make sure you have adequate correction. One point to make is kind of a subtle point over the years we've noticed. We now tend to overcorrect the patients just a little bit because over time, all of these patients tend to lose correction a little bit forward. It's either through some distal junctional issues, even in the AS patients. I was going to make the comment on Dan's talk. If you put them a little head down, if you look in 5 or 10 years, many times their head's even farther down. I don't have a great solution for it because we can't have them falling, but they do tend to migrate forward over time. So we try to put a little slop factor in with a little bit of overcorrection sometimes in these patients, especially if they're open distally, anticipating some correction loss with time. These patients will have a rod fracture sometimes, and they will have some muscle swelling pushing on the spinal cord. So we like to put this cross-linking rod in through W connectors over the 3-column osteotomy. It reinforces the rod, prevents the rod fracture, and it keeps the muscle off the spinal cord and the perioperative period. And this has been invaluable for us over the years. If the patient has fascial dehiscence and anterior muscle migration, we have plastic surgery come and mobilize the paraspinal muscles during the closure. This is not just important cosmetically. Patients that have persistent anterior muscle migration also have more persistent neck pain in my experience, so this is also for clinical outcomes. Post-op, these patients all go to the ICU. We keep their head abed at 30 degrees for swelling. We do a swallow evaluation before they receive any food ever. We keep their MAP greater than 80. If we end up doing them late, we extubate them in the morning, give them early tube feeds if they're NPO, so to maximize their nutrition. We anticipate about a 10 to 15 pound weight loss. Just a couple case examples. This is a C7 apex. So we did a C7 PSO, which is rare for us now. This is a T2, which is a more typical level for us these days, T2, T3. You can see the correction you get with these 3 columns can be quite powerful. And then sometimes we have to do multiple osteotomies, like I mentioned, to get a full correction. This is a patient that had, I showed you before, this patient needed two thoracic PSOs and then a lumbar PSO for final correction with a good cosmetic result. And then the 3CO patients with ankylosing spondylitis, many times these patients are getting multiple osteotomies. This was a case that again required 3-column osteotomies for correction. Correction first in the lumbar spine because the PILL was mismatched. So we start in the lumbar spine on those patients. Then we performed a cervicothoracic 3-column osteotomy. And then finally an asymmetric L5 PSO to correct the overall coronal balance. I'll stop there and thank you very much for your attention.
That was an incredible talk with a tremendous amount of pearls. I mean, I'm so glad this is recorded because there are so many lessons learned through decades of experience, treating patients like this. I'm particularly interested in the CMF plates. I think it's a genius solution to the inherent problem with navigation in the subaxial cervical spine in particular. There is a question from the audience, and it's about rods. Question specifically asks, is the third rod, the accessory or satellite rod, or the midline rod, is that also cobalt chrome as well? And I would kind of piggyback off that question and ask, now with companies having 4.0 millimeter rods, 4.5 millimeter rods, and I think in certain cases, do you typically use a 4.0 rod? Are you still using a 3.5 rod? What's your rod diameter in the cervical portion of your construct?
Yeah, good question. We typically use 3.5 cobalt. If we're going to use titanium, we would definitely use a 4.0 titanium rod. Not a 3.5 titanium doesn't work for deformity. It's just too flexible. So 3.5 cobalt is our rod of choice. And then we typically will, if we do an upper thoracic, we'll try to stay on the 5.5 rod. We can put a 3.5 to 5.5 connector in, and we try to run that third rod as a 5.5 rod, even up into the cervical spine. Um, it doesn't, I don't think it really matters whether it's cobalt or titanium. I think that rod at 5.5 is probably, stiff and durable enough. But even if we're not concerned about rod fracture, I've had a few patients over the years that were very muscular. I think they had some like kind of muscular swelling after surgery and their muscle kind of compressed their cord. They had a post-op issue. We took them back, found absolutely nothing but a lot of swollen muscle. So I just sort of like that rod to keep that muscle off the cord as well. So not only is it stabilizing, but it also just tense up the soft tissues a little bit.
Makes a lot of sense. I think we have one more question. This is Dr. Ames. Could you describe I've actually lost my screen now. You describe the rib release with a T3 PSO.
Yeah, it's very standard. For T3 especially, it's pretty easy. We just take the rib more distally, transect it, taking care to try to stay out of the pleura. And then what I do now is I will literally identify where the pedicle is on the spine, and I will take a chisel all the way through the lateral part of the pedicle, through the lateral part of the vertebral body, and just crack that lateral fragment off almost as a single piece. It gives me direct rib access. So I approximate the pedicle. You have to be, obviously careful if there's a rotational or scoliotic deformity, but I'll just take that chisel just laterally through the lateral part of the pedicle, and it makes the removal of that proximal rib pretty easy. If you get a pleural tear, which a lot of these patients are so frail and, especially if they've had prior surgery or whatever, it's not a big deal. I don't put a chest tube in. I put, suction drains in, and then I check a post-op chest X-ray. And the vast majority of them don't have pneumothoraces that need drainage. So even if you get in the pleura, many of them don't need a chest tube.
Great. One last question I actually have would be predicting and anticipating swallowing issues. Have you picked up any pearls? Because that's one thing that has kind of vexed, I think, us here at Vanderbilt is the inability to accurately predict dysphagia following these surgeries. Any pearls for the crowd tonight?
Yeah, a couple is many of these patients have pre-op swallow dysfunction, but it's kind of subclinical. So we'll send some of these patients where we're anticipating a very significant translation of the head to get pre-op swallow evaluation. And many times they have significant dysfunction already, even if it's subclinical. So those patients are ones we're really careful about aspiration. Keeping them NPO, sometimes with pre-op pegs or things like that if they can't, if they're at high risk of aspiration. That's one. Also, very thin older women with upper cervical deformity tend to have, a higher risk for sure. And we found the obvious in one of the studies we looked at before, which is anterior-posterior patients have much higher incidence of significant aspiration and swallow issues post-op. So it's one reason that in some of our older women, we try to go all posterior if we can.
Great, Pearls. Thank you. With that, I think we'll move on. Our final case presentation and discussion tonight is by Dr. Chris Shaffrey, Chief of Spine Surgery at Duke. Dr. Shaffrey is traveling tonight and was grateful enough to pre-record his talk, and so we're going to play it now.
Good evening. I'm Dr. Chris Shaffrey. I'm a spine surgeon at Duke University and the current president of the Cervical Spine Research Society. I'd like to welcome you to the Cervical Spine Deformity Techniques for Deformity Correction webinar, and hopefully I will show an interesting case which will engender some substantial discussion. These are my disclosures, and the most substantial one is I've developed anterior and posterior instrumentation systems from NuVasive in the past. This 65-year-old woman has a history of camptocormia dystonia and has been followed by the neurologists at other institutions and at Duke for the past number of years. She also has a comorbid history of osteoporosis. Her workup has been extensive. She's had muscle biopsies, nerve biopsies, MRI scans of the brain without being able to have a definitive diagnosis of her condition. She's been treated by pain management and has had a narcotic and baclofen combined pump with a variety of different narcotic agents, but escalating doses of baclofen, and she is currently on 800 micrograms per day of baclofen, which is an exceedingly high dose. She's had attempts to wean the baclofen, which causes marked worsening of her camptocormia and dystonia. She's had multiple Botox injections over the years. She has had an otolaryngology evaluation for substantial dysphagia, and it's unclear whether this is due to her extreme chin-on-chest head posture or whether it's related to her underlying neuromuscular condition. For her osteoporosis, she's been treated with 1 year of Evenity. On the initiation of treatment, she had a T-score of her hip being minus 3.1, a T-score of her wrist being minus 3.3, and Hounsfield units that were in the 70s at the thoracolumbar junction. These are attempts at flexion and extension, x-rays of her neck showing the severity of the cervicothoracic junction. She also has a substantial rotational deformity at the craniocervical junction related to her dystonia. You can see on her patient-reported outcomes that she is severely disabled with this, with an ODI approaching 80. However, on her plain radiographic and the subsequent CT evaluation, it showed that her overall alignment improved while she was in a supine position. And this shows that in the sagittal plane that there is some substantial correctability. This is a 3D generated image of her CAT scan, which does show she has some residual scoliosis involving the cervical and cervicothoracic junction, but she has good correction in the sagittal plane with positioning. So a point of discussion is, with this correctability, does this change the surgical approach and considerations? This is her Hounsfield units of the upper thoracic level. This is at the T3 segment, showing that her Hounsfield units are now 175. And is this sufficient for us to consider surgery? And what would the risk be of distal junctional failure with treatment? So what is our surgical plan and approach, and what levels should we be considering instrumentation and fusion in this unfortunate woman? So what I decided to do, because she was correctable, was going to do a staged approach. One of my considerations was that with her being on extremely high doses of baclofen and her having had several baclofen pump revision surgeries and her becoming extremely ill with the baclofen being interrupted, it was my hope to do a more limited surgery to avoid the need to deal with the baclofen pump, at least as a first stage. So I decided to treat her with an anterior-posterior approach, and you can see the positioning after traction, and she is now 25 pounds of inline Gardner-Wells traction. This shows the preoperative marking for our surgical approach. This shows intraoperatively with cervical distractor pins being placed at multiple levels. This was the completion intraoperatively of her anterior approach, where C3-4, C4-5, C5-6, and C6-7 anterior cervical discectomies were performed, and the placement of a cervical plate. This again shows her AP fluoroscopic image showing some correction of her scoliosis. This is on postoperative day number 2, where I obtained AP and lateral images on her prior to my planned second stage procedure. On the 5th postoperative day, I performed an exposure from C2 to T6. You can see that there are reduction screws being placed both at the C2 level and at C7 through T6. This shows the placement of 4 millimeter cobalt chromium rods. And this shows intraoperatively the fluoroscopic images both prior to the rod placement and after the rod placement. This shows her postoperative images on the 3rd postoperative day after the second stage of the procedure, and this shows the extension down to the thoracic area, but the residual scoliosis at the thoracolumbar junction. So I've told the patient that I would plan a 3rd stage procedure after the baclofen is weaned to a safe level. So hopefully this case presentation will give a springboard for discussion, and hopefully I and my colleagues will be able to answer any questions that you have. Thank you.
Hey everybody, I'm on the call for any questions or for discussion. I think that Dan and Chris, the presentations that they gave, did just such a wonderful job, talking about all of these different issues. So I think the principal thing is that if you have a flexible deformity, the opportunity for doing things circumferentially that Dan and Chris so nicely described really is paramount. And I think that with this, the only sort of subsequent is that she ended up requiring a percutaneous gastrostomy. I knew that, as Chris had mentioned, that she was at very high risk for this. We did a speech and swallowing study after the second stage, and she had some risk for aspiration. So we just put a percutaneous gastrostomy in her. But she is doing extremely well and is very grateful. And I will eventually plan on weaning her baclofen and then taking her eventually down to the pelvis for her distal problem. So hopefully that gives some feed the thought, and it really, I think, exemplifies the wonderful points made by both Dan and Chris and their great talks.
Thank you very much, Dr. Shafri, for the talk. Any last finishing comments from anyone? Dan, Chris, Dr. Shafri?
Yeah, those are really amazing cases. All I can say after seeing all the really amazing corrections that Chris and Chris both get, and the massive operations that you got to do to get them, all I can say is thank God I only do the cervical, because that looks like a lot of hard work and a lot of potential for complications. But there is beautiful corrections, a lot of nice tips.
Thanks, Dan. I tell you, there's not a meeting that I don't participate in where I don't learn something from you and Chris Ames. So I've got to tell you, this has been just an absolutely spectacular session. I want to thank you on behalf of the CSRS, and I want to thank all the participants for this incredible session. And I've got to tell you, between you and Chris Ames, it's truly the world's leading experts in this field, and I just can't believe how many wonderful tips that you guys give to make this surgery actually doable. Thank you, guys.